Good evening, everybody. No applause necessary. It's okay. I want to thank you all for coming, first of all. My name is Marcus Cooper. I'm a gastroenterologist. And as a gastroenterologist, my specialty is guts, really, for lack of a better term. So my friends always tell me that I deal with guts and butts, but that's probably the extent of what I do. And today I'm going to talk about pains in the butt. In addition, because this is Colon Cancer Awareness Month for the month of March, I am going to be talking about colon cancer. So those of you who came to hear something about colon cancer and colon cancer screening, I will be talking about that at the end of the talk. But I'm going to start off with pains in the butt. Now, I know if some of you have seen this topic, you may be thinking that you're going to see pictures of your boss or your spouse or your kids, but this is strictly going to be medical causes of pains in the butt and not anything that you may be thinking of. So I'm going to get started. All right, so this here is the Ebers papyrus, and if any of you are history buffs, you may have heard of the Ebers papyrus before. It is the oldest medical document that has ever been found. And I thought this was kind of interesting because this document dates back to 1500 BC. So that's 1500 before Christ. And even during this time, people were concerned about their bowels. So if you read this is an excerpt from the Ebers papyrus, and it says, "The uncleanness within is greater by much than the uncleanness without. And he who cleanses himself without but remains unclean is like a tomb that outwards is painted fair, but is within full of all manner of horrible uncleanliness and abominations." And this is basically referring to what goes on in your bowels. People have always been obsessed with their bowels. In the Caribbean in particular, and in the Bahamas, everybody's obsessed with their bowel movements and their bowel habits. And this is not anything new. This is going back to the days of Jesus Christ. So this is a very common problem, and I'm going to try and explain some of it for you in very simple terms. So constipation. So if you look on your left and you look on your right, one of you is constipated right now. It may be both the person on your left and on your right. But constipation in the Bahamas is an epidemic. If I see 10 people in my office in a day, 7 of them either come for gas and bloating or constipation. So the common misconception that people come to me and they ask me is, I've been told, or somebody's told me, that you should move your bowels after every meal. And that seems to be a very common theme, a very common question that people have. This is true and it's not true. So there's something called the gastrocolic reflex. And the gastrocolic reflex is that reflex that causes you to move your bowels after every meal. Now, the reflex is only present in babies. And this is why every time you feed a baby, the baby poops, because they don't have control of that reflex. So what happens in the gastrocolic reflex is that you eat some food here, and your bowels prepare to make room for what's going to be coming down the track. And so you empty the end of your rectum or your colon. As we get older, we're able to control that so that we don't poop every time we eat. And women in particular tend to control this a lot better than men. And because women seem to want to, have a comfortable surrounding every time they have a bowel movement. They have to be at home. The lights have to be dim. It's got to be a familiar environment. Men, we can poop just about anywhere. So women seem to have, and what happens here is that after suppressing this reflex over many years, you can develop constipation. So when people say, I've heard that you should have a bowel movement every time you eat, that is true. We have a reflex that regulates that. But if you don't have a bowel movement every time you eat, it's not abnormal. It's not abnormal. And it's something that we control, and over time, we sort of modify it and things change. So what is constipation? Some people feel like if you don't go after every meal, you're constipated. And that's not true. There's a range of what we consider to be normal when it comes to bowel movement. And what's important on this slide, this is actually the medical definition of constipation. You have to fulfill some of these criteria. And I just want to point out a few of these things. So straining is important. If every time you go to the bathroom, you got to sit there for a while and you strain, if you got to take a book or you take your phone and you on Facebook and WhatsApp, it's probably because you are constipated and you're straining for a large percentage of the time. Lumpy or hard stools, and I'll explain this in just a bit with a picture. The sensation of incomplete evacuation. This one is really important. So if you go to the bathroom and you have a bowel movement and you get up and 5 minutes later you feel like you haven't had a complete pass and you have to go back, that's a symptom that suggests that you are indeed constipated from a medical definition. Sensation of blockage is sometimes there, but not consistently. And if you have fewer than 3 bowel movements in a week, so that's pretty much every other day. So what's considered normal is the range of 3 times per day to 3 times a week. If you're less frequent than 3 times a week, then you do fit the definition of constipation. So if you're going once a week, if you're going once every other week, I've seen patients who go once a month. That is constipation. Okay? One of you in here goes once a month, so don't act all surprised. Okay, risk factors for constipation. Women, particularly, much more common than men. And that's particularly because of what I was explaining before about women suppressing that reflex to go every time they eat. Starts in their teens, progresses in their early 20s and 30s. They don't want to go to the bathroom at work. They don't want to go anyplace else but at home. So you hold it, and then you get home and you forget. And over time, your bowels are actually able to accommodate a lot more feces. And so after a while, you don't have the urge to go anymore. And then that's when it becomes a problem. This is a scientific slide, but it just kind of shows how much more women are constipated than men. Men have other problems, but constipation is not usually one of them. The other reason why women are more constipated than men, I mean, stress, it depends on who you ask. I think women are less stressed than men. But I see more women in the room than men here, so I'm going to stick with this. Hormones, as you approach menopause, the hormones that you tend to lose after menopause are responsible in part for bowel habits, and after you lose those hormones, these can contribute to constipation. Hygiene is what I talked about before, and in pregnancy as well. A lot of women will find that their problems with constipation start when they're pregnant, and it just continues on after that. Advanced age, and I put a question mark here because you would think that as you get older, people tend to have more problems with their bowel habits. And this isn't necessarily true. This is another scientific slide. I think I only have 3 of these that shows that this is the age. So as you get older, into your 50s, 60s, and 70s, the Rome criteria is what determines who's constipated or not. And so this basically shows that in different countries, not a huge difference in age brackets with people who have constipation. So 40-year-olds, just as common as 70-year-olds. You see a dip here, but for the most part, pretty much the same. So it doesn't seem like you should have a problem with constipation the older you get. And that actually is important because as you get older, your body becomes pretty well adjusted to everything, and you have a routine, you have a schedule. If you start to become constipated in your 60s, that's a bad sign. That means that this is probably not just regular constipation, and this could be an obstruction or a blockage, and you really should see a doctor about it. Low income, I really don't know how this is coming from medical journals. I don't know how low income really relates to constipation, but I figure when you don't have any money, everything is bad, right? So constipation is probably no different. Medications and medical conditions. So if you are taking any of these medications, opioids for pain. So if you're on OxyContin or Demerol or Pethidine, these things slow down your bowels. Iron supplements, everybody knows that. The more iron you take, the more constipated you become. One thing I do want to say about that is that the type of iron preparation really does make a difference. So every time somebody's anemic, physicians, we usually put them on trihemic. Trihemic is probably the most constipating of the iron supplements. And we have other preparations of iron that you can use that are not as constipating. And if you're on an iron preparation, ask your doctor to switch you to one that's not as constipating. Water pills like Lasix or HCTZ or Natrolix, sometimes they can cause constipation if you're on antidepressants. Allergy medications are very common. Indigestion medications, so Dica and Maalox and Gaviscon, all of those medications can make you constipated. High blood pressure pills, in particular, nifedipine or Adalat or Norvasc, those medications can contribute to constipation. So if you're on these things and you realize that you're having a problem, talk to your doctor. They can switch you to something else. Some of the medical problems that are associated with constipation, Parkinson's disease in particular, very common after you've had a stroke, if you've had any injury to your spinal cord, diabetes, in particular thyroid and kidney diseases, all of these can be associated with constipation. And if you're wondering, why am I having such a problem? It's probably because, and you have one of these things, it's probably more related to this than it is your bowels. Sedentary lifestyle. This is the last medical slide I have, but this is just showing how long it takes for something to move through your bowels. So this person swallowed a capsule, and it took them about 19 hours from the capsule to go from their mouth for them to pass it out. So that tells you that the food that you eat is sitting in your body, and this is in a normal person with regular dietary habits. So this is somebody who has a moderately high fiber diet. 19 hours, if you eat that KFC on Friday, on Saturday, it might be coming out. If you didn't have any vegetables, chances are it's staying in there until Saturday. If it was bamboo shack with macaroni and peas and rice and French fries, it's probably going to take longer than 19 hours. And so this is why fiber is so important. It speeds this whole thing up. Exercise is important because it speeds this whole thing up as well. Now, this is a picture of poop. And if you are fascinated by this picture, you can go on Google, you could download it, and you put it in your bathroom. And then every time you go, you can have a look at it and see where you're at. Now, this is kind of important for me because this tells me, when I ask you to look at this slide, this tells me how rapid stuff is moving through your colon. So if you're seeing this, it means that your food is sitting there for 19 hours or more. All the water is getting absorbed, and it's coming out like goat pebbles. This is not too good. When you have diarrhea or some other medical problems, it's coming out like this. It's watery, it's very soft, you're going multiple times a day. This is very rapid. So what's considered the range of normal is somewhere between 3 and 5. I use this to help me to determine if people are really constipated. So sometimes people feel like they're constipated. They feel like they should be going every day, and they're not. They're going every other day, but they've been going every other day for 25 years, and they're 3 to 5. So when you tell me that you're seeing types 1 and 2, that tells me, okay, stuff is really going pretty slow, and we need to kind of check this out. Poor diet. So if you go on Google, and I did this just today, if you Google Bahamian diet, this is what comes up. I mean, this is typical, right? There's no fiber in sight, unless you suck on the lemon. Maybe you might get some fiber from that. But there's no vegetables, there's no salad, and this is what people eat every day. People who buy lunch, who work downtown or whatever, this is the kind of stuff that people are getting every single day. And so there's no wonder why we have such a problem with constipation in the Bahamas when we're eating diets like this. We're also big on fast food. Wendy's is making a killing. KFC is making a killing. And so until we start to do something about the amount of fiber that we have in our diets, we're going to continue to have problems with constipation. Okay, so when is constipation a problem? When should your physician recommend that you have a colonoscopy? So these are the warning signs that we look for, that we ask patients about. If you have unexplained weight loss, that's a bad sign. If you see blood in your stool, that's a bad sign. Anytime that you see blood in your stool, it's a bad sign. Even if somebody told you, if your Grammy told you or your auntie told you that it's probably hemorrhoids, that's not something for you to decide. You should get that checked out because it's always a bad sign. It's not normal. Unexplained anemia. So half of the population of the Bahamas claims that they're anemic. I'm anemic. I've been anemic since childhood. You don't know if that's true or not. But if you are anemic, there should be a reason why. Women are typically slightly anemic during their childbearing years, when they're having periods every month and they're losing iron. That can make you anemic. But you should not become anemic at 50 or 40 or 60. If you are, that's something that needs to be checked out. Sudden change in bowel habits. If you were going 3 times a day and then all of a sudden it's once a day, or if you were going 3 times a week and now all of a sudden it's 3 times a day. Those have different meanings, but that tells me that we probably need to check out your colon and see what's going on. Significant unexplained abdominal pain. And if you have somebody in your family, particularly a first-degree relative, mother, father, sister, brother, who's had colon cancer, that puts you at risk. And the recommendations are that you should have some sort of colon cancer screening 10 years before that person was diagnosed. So if your mother was diagnosed at the age of 50, at 40, you should be having a colonoscopy. Or if it was 60, then at 50. This is very important because colon cancer tends to run in families. So just some of the treatment for constipation. Fiber. Fiber is the most important thing you can do, especially if it's mild constipation. So you saw the picture about our typical diets. You got to change that. You have to get more oats and bran cereals and wheat and fruit and vegetables into your diet. When constipation is particularly severe, we can use a laxative. This is like Dulcolax or Miralax or one of these things, or glycerin suppositories. But the thing I want people to be most aware of, if you have mild constipation, you really want to be increasing your fiber. Okay, now just one word about fiber. Not infrequently, people will tell me, I eat lots of vegetables. I eat oatmeal every morning for breakfast or cream of wheat, and my bowel movements are still not regular. What you can see from this slide is that regular dietary fiber often doesn't have a significant laxative effect. So even though you're eating lots of fruits and vegetables, sometimes that doesn't work, okay? Similarly here, sometimes it doesn't work. And this is particularly true when you have moderate to severe constipation. If it's pretty mild and sometimes you're straining, but it's not often, these things are good for you. But when your constipation is more severe, you probably need something like supplemental fiber. So we've all seen Metamucil and Benefiber and Consul and Fiber One. These are things that if your dietary fiber is not doing the job, you can put into your diet. And so just some supplemental fiber once a day does wonders for helping you to move your bowels. And prunes. So everybody knows about prunes. Prunes are great, and we've actually had scientific studies that show that prunes work. So this is a straining score. I won't go into detail about that, but you can see that people strain less than normally just by eating prunes. And probably, if you get enough prunes, it's just as good as Phycilium, which is Metamucil. So if you don't like that gritty taste from Metamucil and you think it tastes nasty, get yourself a box of prunes and go to town, okay? All right, so that's enough about constipation. So the second pain in the butt I'm going to talk about is hemorrhoids. Now, if you look to your left and you look to your right, one of you all has hemorrhoids. Nobody wants to talk about it, but it's very, very common, okay? So there's two types of hemorrhoids. You have external hemorrhoids and you have internal hemorrhoids. External hemorrhoids are the ones that you can feel. Internal hemorrhoids, you don't. So if you're seeing blood in your stool, you could, and you don't feel anything, you don't see anything, when you examine yourself, you could still have a hemorrhoid. It just be internal. This is a slide that kind of shows us the types or grades of hemorrhoids. So if you've had hemorrhoids before and you've seen a doctor and your doctor said, okay, you have a grade 2 or second degree hemorrhoid, and you don't really know what that means. So this kind of tells you what that means. So we have some hemorrhoids that are inside that stay inside. Hemorrhoids are just blood vessels. Let me just clarify that. They're nothing abnormal. They're blood vessels that everybody has in their rectum. And from time to time, they get swollen, particularly if you're constipated and if you're straining. So grade 1, they kind of stay inside. Grade 2, they come out. So hemorrhoids pop out, and then they go back in by themselves. That's a grade 2. If they pop out and you got to push them back in, that's a grade 3. And if they pop out and they can't go back in, that's a grade 4. So for people that have hemorrhoids, depending on the type of hemorrhoids you have, the treatment is going to be a little different. So what are some of the symptoms or complaints that people have when they have hemorrhoids? And sometimes they don't even know that they have it. So they may complain about itching or burning or occasional blood in the stools. Sometimes you see blood in the water when you have a pass, and sometimes you just see it on the toilet paper. Like I said before, blood in your stools is not normal, okay? Don't ever assume, even if you've been told that you had a hemorrhoid before, don't assume that that bleeding is coming from a hemorrhoid. So I've seen people who went to a doctor and the doctor told them that they had hemorrhoids, never recommended them to have a colonoscopy, and then a year later, we find that they have colon cancer. So you always want to get checked out to make sure that what you're seeing is really what it is. You can have rectal pain and tenderness, and then when you have external hemorrhoids or grade 3 or 4 hemorrhoids, you'll feel sometimes a swelling at the anal verge. What do we do about hemorrhoids? Lifestyle modification is key. So spoke about fiber already. So fiber, for all your pains in the butt, fiber is good. Increase your amount of fluids. Lots of people don't like to drink water. Or if they drink something, they don't like water. They want juice or they want sodas. Nothing is as good as plain old water, okay? Avoid straining. So if you go and you sit on the toilet and you're on WhatsApp and Facebook and Instagram or you're reading your Bible, I don't have anything against reading your Bible, but you don't do it on the toilet, okay? So that all leads to straining. It leads to swelling of your hemorrhoids. You tend to have more problems. So you want to avoid very long toilet time. So what I tell people, if you go, sit on the toilet, nothing happens in 2 minutes, come back. It's not your time. Okay, so what do we do for hemorrhoids? We treat them with medication initially if they're grade 1 or 2. Some of you may have tried Preparation H. There's something called proctoglyvenol. We have tablets called Daflon. All those things are pretty effective if your hemorrhoids are stage 1 or 2. But for something more severe, you tend to need something else. And this is where the banding comes in, and then maybe surgery. Now, I had a really cool video. Can I just go behind here and see if I can play it? See if it works. Oh, it works. Cool. Okay. So this is something that we're doing at my office now. This is new. So previously, people thought that hemorrhoid treatment was painful, and surgery is painful. Surgery for hemorrhoids is probably the most painful surgery ever. It's worse than having open heart surgery. So this procedure can be done in about 15 minutes, and what I do is I insert this device here, which is about the side of my finger, and you can identify the base of the hemorrhoid. I don't know if can they show this on ZNS? I don't know. This Urca might have a problem with that. So anyway, you find the base of the hemorrhoid and you pull it into the device. I make sure that you're not having any pain, and then you put this black thing here called a band on it. This takes 5 minutes. You can go right back to work. and it's totally painless. So hemorrhoid surgery, hemorrhoid management is no longer painful. This is something that you can have done without having to have surgery. Okay, so that's all I'm going to say about hemorrhoids. We're going to move right along. Anal fissures, the other very big pain in the butt. These are extremely painful. Anal fissures are small tears in the anal canal. Sometimes you don't even see it. But these things will cause you to have pain for hours. And I've seen grown men come into my office and fall on their knees because of fissures. So what happens is you go to the bathroom, you have a bowel movement. It's very, very painful having a pass, and the pain lasts for about 7 hours after, and people feel worn out. They have to go and lay down because they're just so tired. So these things are extremely painful, and they don't get better unless you treat them. So some reasons why people develop these fissures are because of trauma. If you know, people who ride bikes a lot or who do horseback riding. Constipation is a very common cause, or even diarrhea, if you're going a lot, can cause you to develop a tear. Childbirth. I don't know exactly how childbirth can cause a fissure, but maybe one of the women in the audience. Pushing. There you go. That's my mother, by the way, so I'm not going to dispute that. And sexual abuse, every now and then you'll see somebody who comes in with a fissure. Once people come in with a fissure, or before they come in, these are some of the symptoms that they have. So you see a little bit of blood, not a whole lot, just a little. You'll have this anal pain that lasts for hours, which is usually the telltale sign that what you're dealing with is a fissure. We do a test that checks for the pressures, and the pressures are tight because the muscle is in spasm. So at the end of your rectum, there's a muscle that you can relax to allow stuff to come out, and this thing is in constant spasm. It's very, very painful. And that spasm is also what prevents the fissure from healing. When the muscle is in spasm, it doesn't allow blood to get to the area where there's a tear, and so the tear doesn't heal. It's usually always in the back. If it's in the front, it sometimes suggests that there's some other pathology going on, but typically 90% of the time, the tear is in the back. This is not too important. So what do we do for fissures? Again, fiber. You can't go wrong with fiber, okay? So from this talk, you should go to the nearest pharmacy and get yourself some Benefiber or Metamucil. It cures all pains in the butt. Sitz baths. So that's when you put Epsom salt in some warm water and you just kind of sit in it. That helps as well. Topical anesthetics would just be lidocaine, and that comes in a gel. You can put it around the area when it's painful, and topical anti-inflammatories like Voltaren, etc. What I do, once people get to me, it's usually because these things haven't worked. And so what I do for fissures that works really well is Botox. It's the same Botox that you put in your face for wrinkles. And so when patients insist, I will save some of this and put it in their face for wrinkles. So we put the most of it in your butt. I don't actually put it in your face. I send you to Dr. Neil, and Neil can put it in your face. But it's the exact same drug. And the same thing it does for the muscles in your face, it relaxes the muscles. It does the same thing for the muscles in your rectum. And by allowing that muscle to relax, you allow the fissure to heal. So Botox is very effective. I've only had about 2 patients who did not respond to Botox who required surgery, but this is something that really works. Okay, and last but not least, I'm going to talk about colon cancer. This is Colon Cancer Awareness Month. You know, we as physicians, not just gastroenterologists, but we as physicians are trying to get people as aware of colon cancer as they are of breast cancer and prostate cancer. So colon cancer screening to prevent colon cancer is very important. What are some of the risk factors for colon cancer? Sorry. Being overweight. So in our population, that's probably about 70% of us if you go by the BMI calculators. So we have an overweight population. That's a risk of colon cancer. High-fat diet. So that Bahamian diet with the macaroni and the potato salad, and the peas and rice, high fat diet, and very, very low in fiber. Smoking, which doesn't seem to be a huge problem in the Bahamas, and in family history. What's really important about this slide is the diet. So, since I've been home, and it's been about 7 years, 8 years now, I just been kind of observing the things and the things that people eat. And very recently, within the past year or so, we've been seeing a lot of stuff on WhatsApp, a lot of these videos that have been circulating on social media about some of the foods that we have here. And I really believe, and it's just a theory, but I think it's true, that the foods that we get, because they're imported, and we rarely eat things that are grown in the Bahamas, that the chemicals and the dyes and the preservatives and the stuff that's in our food is killing us. And because we ship everything in, and the manufacturers and the retailers want to make sure that it looks good when it gets here and that it's still relatively fresh and it hasn't expired, but a lot of times we're eating garbage. And we really need to, and I'm hoping that this is a part of the NHI initiative, but we really have to be more conscientious about what we eat, especially what we give our kids to eat. Because, if we start them off with these high-fat, low-fiber diets and grease and fast foods every week, we're setting them up to develop not only colon cancer, but high blood pressure and diabetes and all that kind of stuff. So I just want to kind of make sure that people understand the importance of diet with all medical problems. It's at the foundation. Okay, so what are the symptoms of early colon cancer? Does anybody know? This could be an interactive kind of a talk. Not all at once, please. So, there are none. That's right. So, early colon cancer, you don't feel anything. You don't have pain. You don't see bleeding. You don't have anemia. Sometimes you don't see anything. And this is why it's so important to get a colonoscopy routinely after the age of 45. You don't want to wait until you have symptoms. Once you have symptoms, you have a problem. And the symptoms that people typically complain of are the unexplained weight loss. They start to see blood and stool, change in your bowel habits, like I mentioned before, unexplained anemia, and abdominal pain. Once you have that, it means that your problem is advanced, and we're going to have to do a lot more to get you fixed up. So why do we do colon cancer screening? So when we do a colonoscopy, we're looking for polyps. Polyps are like pimples. And this is an actual polyp. It kind of looks like broccoli, and it's on a stalk here. And when you have this polyp, you don't feel this. So we go in, we do your colonoscopy at the age of 50 or 55, and we find one of these things. And it takes me maybe about 6 minutes to remove this during a colonoscopy. And we send you on your way. We send it to the lab. If it comes back as a benign polyp, a non-cancerous polyp, then you don't have to repeat your colonoscopy for another 5 or 7 years or even longer. So we want people to come and get their colonoscopies when we can remove these things. What we don't want is when it looks like this. And now the polyp is so big that it's obstructed the opening of the colon, and now you're having constipation, and now you're seeing bleeding, and now you're having pain and you're having weight loss. So you can see the difference between the polyp and what we see here. So once we see this, now I can't do anything during a colonoscopy. So I have to send you to surgery, and after surgery, you're going to have chemotherapy, and sometimes you may need radiation depending on the stage of the tumor. So the importance of a colonoscopy is to detect this so that we don't have to deal with this. So here are some of the things that we do for colon cancer screening. So colonoscopy is only one of them, okay? We have stool tests, which we do every year. This checks for blood, but you want to get these things early, so the colonoscopy is probably a better way to do it. But you can do a stool test every year. If you're deathly frightened of having a colonoscopy, having a stool test done every year is an acceptable method of colon cancer screening. Barium enemas are a type of x-ray where they put some dye into your rectum and it fills the colon, and this tells us if there's anything abnormal or irregular going on in your colon. A CT colonography or virtual colonoscopy is like a CAT scan, and this is what Doctors Hospital has at their system. A virtual colonoscopy is not invasive like a real colonoscopy is. It has its advantages, but you can't remove a polyp if you see it. So you may have to have a real colonoscopy if they find something on a virtual colonoscopy. Now, I use these virtual colonoscopies in people who are not good candidates for colonoscopy. So if you've got heart disease, or if you have lung disease, or if you're on a blood thinner and I don't want to stop it and bring you into the hospital, I might say, okay, my suspicion that you have something is low. Let's just do a virtual colonoscopy and see if there's something that we need to deal with. And what the CT scan does is it creates an image of the inside of your colon, and it allows the radiologist to fly through your colon with this software and see if you got any pimples or something that looks like a polyp. And once they see it, they then report it to us, and then we go and we look for it. So virtual colonoscopies are definitely useful in a certain population. And it's available at Doctors Hospital. So that I put that plug in for them so that they invite me back some other time. Okay, so this is what a regular colonoscopy looks like. The colon is nice and clean. So the advantages of doing a regular colonoscopy is we have the ability to go into the colon and clean it up. And if we see a polyp, we could remove it. And this is what a perfect colon looks like. It's nice and pink and healthy. You can see all the blood vessels. So colonoscopies are very useful, especially if you follow the recommendations about the preparation, so that we can see if there's any polyps and remove them at the same time. Okay, so in conclusion, covered a lot of information there. The important things to prevent yourself from having any of these problems, not just colon cancer, but all the others, is to have healthy bowel habits. And the way that you do that is by exercising, by eating healthy, and getting checked out. If you have symptoms, don't assume that your symptoms are something. Go to your physician, go to a healthcare professional, get yourself checked out. Listen to your bodies, all right? Everybody kind of knows when they don't feel well and they think that something is wrong. And a lot of times because we're busy, we put it off. Don't put things off. Get on top of it early so that we can take care of it and help you to live long and productive, healthy lives. Thank you.
You've been watching Doctors Hospital Distinguished Lecture Series, presented every third Thursday in the month. Thank you for joining us.